Hi, so yeah, my name's Amy. I'm one of the oral surgery registrars at the Royal National Ear, Nose and Throat and Eastman Dental Hospital. And we have a brand new head and neck facility here, which has given us a scope to improve our services and bring our patients into making a lot of those decisions. So hopefully no one will come in and disturb because I am in a clinic room. Next slide, please. So imagine this scenario. You go to see your dentist and they spot something in your mouth that concerns them. You're seen days later in the hospital and you have a biopsy of that area. And it turns out it's cancer. So that's devastating news. Now, within a week, you are having scans and lots of other tests, and you have a discussion with your multidisciplinary team telling you that you need surgery and chemotherapy and radiotherapy. Now you're told after the surgery, you may not be able to eat again, you may not be able to talk again, you may need a permanent tracheostomy to help you breathe. Your face will not look the same. Now a short time later, you have a dental assessment by the hospital team and they want to remove 15 teeth tomorrow. And this is the pathway that every head and neck cancer patient faces. Next slide, please. So oral cancer is the 6th most common cancer worldwide, but with increased awareness of risk factors and early diagnosis, treatment can be effectively managed with minimal post-operative patient morbidity. Next slide, please. Now we had a new guideline to work to. So the Royal College of Radiology gave us the guideline that any treatment has to have been completed. This is dental extractions within 14 days. So they want to start their radiotherapy treatment 14 days after basically being diagnosed. Now, for dental extractions, we need about 10 days for it to heal up, for its initial bit of healing. So that basically gives us 4 days in order to take out a patient's teeth from when they've just found out that they've got cancer. So it's very quick. Next slide, please. So I mentioned before that the treatment is surgery and chemotherapy, but a big part of it is the radiotherapy. So apologies for not putting a picture of a mask up, but for those who may have seen one, they have to have a mask that holds their head in a very still, very specific place. So it's into every nook and cranny. So they can't have any swelling when they go to have their mask fitting. So that gives us another time constraint. Now we have something called ORN, that's osteoradionecrosis of the jaw. Now what that is when you have radiotherapy, it kills off all the cancer cells, but unfortunately it also kills off a lot of the blood vessels there, so the bone can't heal very well. So if in the future you end up having a dental extraction, it doesn't heal and the bone can die. Next slide, please. So it's really important as part of our role that the team can assess and decide which teeth are going to make it and which teeth aren't. So any tooth that doesn't look like it's going to last forever is likely that they need to come out. Now, unfortunately, for some people that can be all of their teeth if they're not very well looked after. For some people, they can have what they feel is a relatively good mouth, but actually, when we look at x-rays and when we look at our clinical side, we can see that they may still need a lot of extraction. So it's a big shock for the patients. Next slide, please. So originally, the patients used to come to the restorative dental department of the hospital, and they would be seen by the clinician that was available there, and they would be referred to the oral surgeon, so that's somebody like me, to have any extractions, and they'd be asked to see their dentist for any other fillings or cleaning that they need. Now this was a big problem really, because the patients, when we asked them, they found that it's really overwhelming. They almost feel rushed because they're going from one department to another department to another department. They've got to go see their dentist. They've got to come back and they're also seeing all their cancer specialists as well. And because this is all done so quickly, you can understand why it's so overwhelming for these patients. Next slide, please. So we created a new pathway, and we have the NDT, which now our dental team is part of. So the oral assessment happens very quickly, and they've already met some of the team, which is much better for the patients. They feel much more comfortable. Once they've had their assessment, they are having the treatment with us. So our restorative team or our special care dental team are completing any of the dental treatment, and the oral surgery team do any of the extractions. So they're all in one building, it's all organised at the same time, and they get to meet everybody involved. The other thing is that we are looking after their follow-ups as well. So it means that they're not lost. They don't feel like they've just been abandoned after they've had all this dental treatment done over a couple of days. Next slide, please. So we're all on one page now. The patients understand what's going on. Everybody's looking at the same thing. Everybody's talking about the same thing. And because the assessments are now carried out by senior clinicians, so registrars and consultants, it means that they already have a relatively good and very experienced patient manner, which is actually always really helpful as well. Everybody's kept involved, all the clinical nurse specialists, all the oncologists, and the patient, most importantly. Next slide, please. So communication has made a huge change for us. So that was based on what our patients felt, that at each stage they found it really difficult to communicate. They're not sure who they're seeing, when they're seeing them, and they've never met them. So that's made a really big change for them, and they've consistently said that it is much better and they're much happier. The review makes all the difference as well, so they do feel like they've got a hub to come back to if they have any problems. We have made new patient information leaflets as well, and this is something we use patient focus groups to tell us what they felt they needed to know, what stages they wanted to go through, what they would be feeling afterwards. And these have already been made and the patients see them, but we're, based on what the patients have said, we're also creating some new leaflets that encompass a much larger amount of information for them, which is something that they've also requested. New slide, please. So alongside the patients and the MDT and the communication, we feel that the system as a whole, being that we've come to a new building and we've been able to integrate this so smoothly for them, has made a massive difference to our patients. When you're faced with a change in guidelines that affects a group of patients that have already been given such awful, devastating news, you have to take into consideration their emotional state, and we have to be wary of our own time constraints as well. So we have learned about what information they want to receive, how they want to receive it, and ultimately this does come down to good informational leaflets that they can take away and come and ask us questions. The timelines alongside everything are supported from each subspecialty, so they have many options to go down for each patient. Streamlining the dental pathway has greatly improved their experience, as there's minimal disruption and improved communication between the teams, overall putting the patient first. Next slide, please. So thank you very much, and it's been a very interesting morning, so congratulations to you all, PENNA too.